pretty much nothing has really changed very much. This is obviously a month on to when we last looked at these, and COVID has stayed level since May, June time. Maybe even starting to drop off a bit, but it's significantly more than it was beginning of the year. So it's not really peaking and showing huge amounts of cases, but it has gradually climbed most of this year, and it seems to be leveling off now. So still nothing really that much to worry about as long as you've got your vaccines up to date, if you are particularly vulnerable. Flu is at a low, as we would expect in the summer. RSV the same. These will start to surge as we get into September, October time, usually. And the common cold, rhinovirus, pretty much stays the same all the time. So that's nothing really remarkable to talk about there.
You can't see that graph.
Now, questions. The last few months, I've been, instead of thinking of subjects myself, I've been asking if you guys have got any questions. And as of yet, everyone's always had really good questions. So I've opted to answer two of the questions asked in Facebook in this last week, as things that are of interest and practical interest as well. So a favourite subject. Hang on. I'm on the wrong side there, aren't I? Why has it gone over there?
Can't see the graph.
Okay, hang on a sec.
Thanks.
There we go. So if I click on this, it opens up over there. Oh, hang on, I've got to change that, don't I? Normal. Yeah. Can everyone see this satisfactorily? I hope so. Okay, so that was the graph I've just been talking about. As you can see, COVID is kind of leveled out in the last month or so, and the others, RSV and influenza, are at a low. Rhinovirus has pretty much stayed the same. So questions. A topic that I'm sure will carry on coming up regularly is biologics. We covered one aspect of biologics last month, but someone asked the question, why do they not always work, or why do they only work for some people? So I looked into this to see what details we know already. I mean, it's fairly early days yet to know all of the reasons why this might be happening, because they've not been in use for more than a few years, but there are quite a lot of details already emerging. We all know what I think what biologics are. These are medications which are actually antibodies made to attack particular parts of our immune system. And the overall effect is that if you take out one of the almost like the junctions of our immune system pathways, then you stop a pathway happening and you can cut down on inflammation, but in very specific ways. This is completely different to when we take oral steroids. That's a much more blanket suppression of the immune system. Effectively, these biologics are acting as medications which do a similar thing to your oral steroids, but they're doing it in a much more precise way, so you don't get all the side effects that you do when you're taking oral steroids for a long time. A long time being more than about a month. So the hope is that these are going to be essentially things that get a lot of people off taking a lot of steroids, and they'll be able to use these new medications to achieve that. Yeah. There are lots of them that are in use, and these are the ones. This is the collection of biologic medications that are currently in use for respiratory issues. They all end in MAB, as you can see. And the reason for that is they are all monoclonal antibodies. So anything ending with MAB is an antibody. This is very similar to the antibodies your own body produces when you have an infection. So they are circulating in our blood. We can't take any of these as a tablet or a capsule because they are essentially proteins and they would be destroyed by the acid in our stomach if we tried to do that. So these all have to be injected, but they're having very precise effects and very good effects. There's a lot of choices depending on what you want to use them for. Omalizumab is probably one of the first ones used. With that, its target is IgE, which is again is part of your immune system that's important for allergy and allergic response. So it is used against allergic forms of aspergillosis and also allergic asthma itself. And then there's a whole collection of others that have come along, different targets, something called interleukin 5, and then there's interleukin 5R alpha, interleukin 4R alpha. These are just all different junctions in the dense network of pathways that form our immune system. I showed you a map last time. I don't think I've got that slide this time, which just showed you some of these pathways that we are trying to block. But there are lots of them and they're often interlinked. So if you block one, you can block off multiple other pathways. And that's what was happening with these alarmins, which are the more recent ones. Tezepelumab, I think was mentioned earlier. It's one of the more recent ones. It attacks part of the immune system that's very sort of early on in a pathway. So if you can stop something earlier, you can block more immune pathways, more immune outcomes. And consequently, these have the broadest use and tend to be more effective as against some types of type 2 asthma because they block more things essentially. And you can see similar theme. IL-5 is obviously a popular choice to block. But does it work? Was the question. So let's just roll on. Okay, what are they good at? Well, if you block IL-4, IL-4 helps B cells make IgE. So if you're blocking it, you can cut down on IgE, you can cut down on that allergic response. Before blocking it, it drives allergy, activates Th2 type 2 allergic immune cells, which we covered last time. So that's one way of blocking an allergic response and making someone who's got an allergic disease feel better. IL-5 stimulates eosinophils, so if we block that, we can cut down the number of eosinophils. And there's a certain subgroup of asthma called eosinophilic asthma that will be helped by this medication. So they're all, including ABPA quite often, because ABPA is quite often is a type of severe asthma essentially, and SAFs is something very similar. So blocking IL-5 helps all of those groups, and we know that they work well for some people, well for quite a lot of people. And there are a variety of other targets, IL-13, IL-25, these are the ones, the alarmin blocking ones, which are coming next. They're sort of the next generation of biologics that are emerging as we carry out more clinical trials to establish how well they work. But how well are they? This is what they should do. This is what they should block. But how well do they perform that task? Wait a minute. I did remember that. There you go. There's the roadmap. Here's all the paths to inflammation described by arrows and the different cells that they work on. You can see this is tremendously simplified. And when you get a pathway with a line across, that means blocking. So tezepelumab blocks the activity of TSLP. These other monoclonal antibodies block IL-33 and so on. You can see how complicated it is. Basically, the purpose of putting this up is the IgE being produced all the way down here, so you can see the rather long pathways that are involved, and every junction of this pathway is a potential place we can block with these medications. I think we covered all that last time. How well do they work? This is what we really wanted to know from the question. So omalizumab targets IgE, like we just said, reduces exacerbations. So this is used for types of asthma where people are constantly maybe having 2, 3, 4 exacerbations in a year. Does it work? 30 to 50% reduction in exacerbations for most patients, which is, to me, that doesn't look like a lot, but it's very effective for most patients. But some patients can reduce or stop oral steroids. So some, not all, but it does. We get complete stopping of oral steroids for some. Reduction in exacerbations for most, it works quite well. And we've got various members of this group and other groups using omalizumab and are finding that it does work extremely well, assuming that this is the molecule that is causing you your major symptoms. Other biologics have different targets. Mepolizumab blocks more than 50% of exacerbations, so that's arguably that. For this group of patients, it works a bit better, and about half manage to reduce maintenance steroids significantly. So it's tremendously successful at reducing steroids, and if we can reduce steroids, we can reduce all those steroid-specific side effects that we're also familiar with. These are very successful at doing that. Benralizumab targets the IL-5 receptor. Now we're talking about up to 70% reduction in exacerbations. So it's almost as if we're going through time here. That was the earliest. Omalizumab was one of the earliest. Benralizumab is more recent, is more effective, and is better at reducing or stopping steroids. Dupilumab. Now we're targeting two things at the same time, two interleukins at the same time. Maybe not quite as good as pembrolizumab, but maybe this is a different group of people. It's still highly effective, and up to 70% can taper steroids. And then this is probably the most recent tezepelumab, which was mentioned earlier. It blocks quite early, right at the top of the pathway. Works particularly well for non-eosinophilic asthma. So you would use this for non-eosinophilic, and you would use one of these others for eosinophilic, this one, I think. So you can see they're used for different groups of asthmatic people, because different people with asthma can have similar symptoms, but the cause can be quite different. And we're still waiting on how much steroid reduction is possible with tezepelumab. So overall, they work really well. So this essentially is saying what we've just said. In clinical trials, 50 to 75% of patients on biologics are able to reduce or eliminate their daily oral corticosteroids, which is fantastic for most people. Real world studies. So that's in a clinical trial where lots of things are controlled. In real world studies, things can be very different. In the real world, people do things we wouldn't like you to do, like smoking cigarettes, like a poor diet. Quite often, what else could be? All kinds of things can be active in the real world versus a clinical trial. But in real world studies, we can confirm that this result carries through. So even in the real world, these things are very effective. And that's why they're finding so many uses at the moment. And the oral steroid sparing benefit is a major reason for prescribing them. So the carry through is we are managing to effectively reduce the amount of steroids that patients get, in most patients are able to do, are taking. These are significantly reducing steroid side effects. And these are steroid side effects, as we know, are pretty major in many. Bone weakness, osteoporosis, adrenal suppression is covered a lot in our support groups at the moment, where the adrenal glands of the patient are unable to produce enough steroid to compensate. They get turned off, and once they're turned off, it's hard to turn some of them back on again, causing all sorts of problems and potentially cortisol crisis. Weight gain is another one. So even in the real world, these drugs are proving to be fantastically effective, but not for everyone. Who benefits most? Frequent asthma exacerbations we've covered. People who've got problems with high IgE or eosinophils, so ABPA, quite a lot fall into this category. Very good at reducing dependence on daily oral steroids. Very good at treating asthma with overlapping allergic or eosinophilic patterns. So again, rather like ABPA, and coexisting conditions like ABPA or chronic fungal sensitization are proving to be pretty effective. I've just noticed this morning there's a big trial that's been running for some time on I think it's pembrolizumab since about 2021, and that has just finished in July, early this year, or was it late last year? And we don't know the outcomes yet. But it was a big trial. It was global. It went all across the world. So it's whatever the outcome of that trial might benefit people with ABPA, because all of this is known, despite the fact that none of these drugs are recommended for ABPA or chronic fungal sensitization. These have all been used in a sort of semi-experimental way to try and see if you can help people with ABPA, and they have worked spectacularly in some cases. But we didn't have the evidence, and this new trial, which is just closed, or closed about 9 months ago, will hopefully provide evidence, and hopefully authorities like exist in the UK for NICE for the recommendation of new medications for the treatment of particular diseases. Will be able to come out with a recommendation to treat ABPA itself with these drugs, or at least pembrolizumab, I think it was. I'll have to look it up. So that's great. But yeah, sometimes they don't work. Why don't they work for some people? Well, first of all, we don't have a brilliant way to detect the different forms of asthma. You may have noticed that doctors discuss very deeply when you've got a certain type of asthma, and they have to go and run all sorts of tests to detect which particular type of asthma you might have. And it can be a very difficult job working out what particular asthma you've got. And one of the reasons why a biologic might not work for you is it might be telling us that you haven't got the right asthma type. It might look like you've got the right asthma type, but if the drug's not working, maybe there's something wrong in your diagnosis. So the biologic is doing its job, but it's working at the wrong inflammatory pathway, and it won't help you. That particular one won't help you. But as you know, we've got another 5 to try, or another 4 or 5 to try. And in particular, the ones that attack more than one pathway could cover maybe one pathway isn't part of your asthma, but the other one is, and that will work in your case. So to a certain extent, we have to go through until we find one that works for you. Right, yes. So you could be diagnosed with the wrong asthma type, and we've tried the wrong biologic to start with. It could be that you've got a type of asthma that's not the regular allergic type of asthma, in which case the inflammation is not driven by eosinophils or other allergic pathways. So the current biologics mostly are active against type 2 asthma. If we discover that you don't have type 2 asthma, then they won't work for you either. There is work going on to develop biologics for non-type 2 asthma, but they're not yet available. So you've either got the wrong type asthma type or non-type 2 asthma as two possibilities. And there's more. If they don't work, you may have fungal colonization. We know all about this. The ABPA is a fungal colonization. And the amount of biologic you're getting is overwhelmed by the fact that there's so much allergic response being triggered by Aspergillus in your ABPA. It drives inflammation so hard that the biologic is working, you're just not getting enough to impact your particular health situation. So it's literally the job's too big for a particular biologic. Fungal exposure like Aspergillus may continue to stimulate inflammation despite biologic treatment. So that's another possibility, and one that's very relevant to this group. You may have been, for example, if you're taking a lot of oral steroids, you may have other illnesses going on that you or your doctors are not aware of, because they're masked by taking that quite powerful medication. So if you've got underlying issues that have not been recognized, they may interfere with the treatment for allergic asthma that you've tried with your biologic, and they may overpower, and you'll still get symptoms caused by underlying illness, essentially. Underlying illness that isn't being treated with your biologic. So unrecognized comorbidities is another potential problem. Some patients aren't particularly good at taking their inhalers, especially youngsters tend not to take their steroid inhalers, for example. I listened many years ago on Radio 4. I think a young man had sadly passed away in some pretty tragic circumstances, and he was taking his reliever inhaler, but he didn't used to take his steroid inhaler because it made no apparent difference to his symptoms. And of course, we know that the steroid inhaler is long-term protection. He didn't bother taking his steroid inhaler. Poor adherence to inhalers. Biologics aren't meant to substitute for that situation, and so you can fail on the fact that you're not controlling your underlying issue with your existing medication, so the biologic is being given too much to do and it won't work. Even incorrect technique might be an issue. This one is the one that I thought would be much more common, because these antibodies, the biologic is a protein antibody, then your body potentially could recognize it as an invading protein of some sort and make antibodies against the antibody, thus inactivating your biologic. In other words, the immune system attacks the biologic medication you're getting. If it does that, it's not going to work because it's been destroyed by your own body. This, thankfully, is rare in omalizumab and dupilumab. and hopefully for the others, but it does happen sometimes. And that would probably take a blood test to work out, to identify if that's what's happening. So, what have we got here? This looks like a summary. So, to sum up, dose frequency of your biologic is too low. You're not treating enough. Sometimes if you use a higher dose, it can work. And this was certainly the case in the early days of omalizumab. Some people were just, the IgE count in their blood was just too high to be able to give them enough. Some cases we started off quite low and the amount of IgE was much higher, didn't come down by very much. So after subsequent blood tests, we increased the dose and that was then effective. So it can be about the dose of what you're taking, or misdiagnosis. The symptoms that we're worried about aren't actually from asthma, they're from your COPD, they're from heart disease, both of which can cause breathlessness, anxiety, vocal cord dysfunction, which is an interesting one, or chronic infection instead of asthma. So they're very specific, they're very useful, but their specificity can work against them, because if it's not exactly if they're being used for something that is not the problem, then they won't work at all. It's not that they'll only work a bit, is they won't work at all, because actually your underlying problem is something like these and not from the immune dysfunction that we thought it was. We're getting better and better at spotting that sort of thing, of course. So biological mismatch. Yeah. You can, so giving an anti-IL-5 biologic to someone whose inflammation isn't about eosinophils won't work, because the anti-IL-5 is about restricting your eosinophil inflammation. Sometimes it's part of your immune system, your cell type. You don't have enough receptors that are being targeted, which is what this R-alpha was all about earlier on. So if the way your cells are set up, it just isn't compatible with this type of medication, then it won't work. It could be that because, especially if you've had asthma for some time or breathing issues for some time, your lungs are already, like would happen with someone with CPA, your lungs have already changed quite a lot, kind of physically and functionally. So even if the biologic works, then a lot of the symptoms will remain, because all that persistent damage is permanent, and the biologic and the reduction in inflammation can't make any impact on that. And of course, ongoing antigen exposure. We know ABPA, we talked about earlier. The antigen exposure is actually inside your airways, so that is an ongoing antigen exposure. But also the mold spores and allergens that you breathe in from maybe a damp home could cause a biologic treatment to fail due to ongoing antigen exposure. And this again, neutralizing antibodies is rare. So the situation where your own antibody, your own immune system fights the biologic is rare. Can occur, but is rare. So I think that's a summary. So in summary, not responding doesn't mean failure. It might mean the biologic was not the right match in your case. It might mean you've got underlying health issues that need addressing. The biologic might be working, but you've got other things that you need to address. And maybe your particular diagnosis isn't quite right, and we need to reassess and maybe switch you to a different biologic in order to trigger the response that we want. Combination with other treatments is usually done and can be helpful. So if using biologics in combination with other treatment is often not only helpful, but is essential sometimes for them to work. Biologics are not really intended to be standalone therapies. They work as part of a personalized treatment plan. So something that works for you might not work for somebody else. It's personal to you. and that means working out what biologics work for you, what co-administered other treatment works for you, such as an inhaled corticosteroid is often taken alongside a biologic. Even if the biologic works well, doctors would normally be very reluctant to stop your inhaled corticosteroid. Things like bronchodilators, the so-called long-acting bronchodilators, plus a biologic, often essential for symptom control, helps open airways and reduce breathlessness. So these are used together. The biologic isn't going to replace this medication. And similarly with antifungal treatment, in this group's case, it could be that you still take an antifungal drug along with your biologic. And because they're doing different things, the antifungal drug is reducing the allergens that you're inhaling alongside the biologic. They may work together, reducing the fungal burden. And this is quite a new approach at the moment. It's essentially being researched at the moment. Early news is that this combination is actually working really well in fungal asthma. So that's encouraging. What's the purpose of this? Yes, this is more examples of the same thing. Oral corticosteroids, not just your inhaled corticosteroids together. The goal is to gradually taper down the oral corticosteroids, have a steroid sparing effect, hopefully stop the oral steroids, but not, of course, any inhaled steroids that you've got. The ideal would be to carry on with the inhaled corticosteroids, but taper off these oral corticosteroids as much as possible while taking the biologic. Of course, this might change over time. Mucolytics can help with your biologic, especially with illnesses where there's an awful lot of mucus, with bronchiectasis or fungal colonization. So SAFs and CPA can be very useful if you use the biologic in combination with the mucolytic. Environmental control, I think we mentioned earlier. If you're having issues and maybe you've got a damp home or spores in your home, if you take action to purify those out of the air alongside a biologic, it may actually help maximize the benefit caused by your biologics on your asthma. Key points: biologics do not replace inhalers. Okay, so stopping them can lead to worse control. Biologics are intended to reduce your dose of oral corticosteroids, not inhaled corticosteroids. Treating coexisting conditions is important alongside the biological effect, the biologic medication. So GERD, sleep apnea and obesity need to be treated alongside taking the biologic. The combination therapy is tailored and research is proceeding at the moment in this area. It's going to be different for ABPA, eosinophilic asthma, SAFs, and fungal bronchitis probably need different things. So there's a lot of work to be done on working on what's best for these groups of patients. And of course, like we said earlier, if one biologic doesn't work, there's another 4 to try to see if they will work alongside all these other ways. So it's quite a job to work out what the right biologic is for you in your situation, and what is actually in your situation. What are the underlying illnesses that you've got? What are the treatments that will benefit you in particular? It's almost coming down to personalized medicine in some ways, but these are a terrific tool, but they've got to be used alongside other tools to maintain your control over your asthma. What's this saying? Used alongside standard asthma therapy, you get greater improvements in asthma control, quality of life, reduced exacerbation. So alongside your inhalers, while cutting down on your oral corticosteroids. In ABPA, omalizumab and antifungal therapy is shown better outcomes than either alone. This is a fairly new study. So if you've got ABPA and you've tried omalizumab and it didn't work particularly well for you, it seems that if you use them together, then you get a better benefit, a better outcome than if you use them, either one of them apart. So a lot of people in ABPA are on antifungals right now. But if they were also on omalizumab, they would get an even better control of their ABPA. In severe asthma, eosinophilic asthma, biologics help reduce steroid use, but inhaled corticosteroids and those long-acting beta agonists remain foundational. Those are very important that you keep taking those alongside your biologic. Biologics are not going to do all of the job all on their own, essentially. And that is that. I hope that was useful. Yes,
So,
carry on.
that's a question. So